But right now, I'd like to introduce the keynote afternoon speaker, and that's Camille Ragin. She's going to talk to us on addressing racial disparities in cancer. So it's the other half of the conversation. And I would say that I still am willing to paddle upstream to get good data. Thank you.
Good afternoon, everyone. All right, so it's really an honor to have this opportunity to talk about one of the things that I'm very passionate about, which is to really address cancer and address racial disparities in cancer. And I'm going to take a slightly different perspective from some of the talks that I've normally given by not being too science heavy. So hopefully the message will still be relayed. So I'm going to start off, because I'm a molecular epidemiologist, I have to talk about the epidemiologic transition, because I think it helps us to put things in perspective in terms of where we are today and how we are in the state that we are in, and what this means when we talk about racial disparities. And so, you know, for the past 100 years, there really have been three distinct ages that we know of: the age of pestilence, the age of receding pandemics, and then finally the age of degenerative and man-made disease. And that's really where we are today, stage 3. But just looking back, you know, pestilence, this was a time where we had high mortality rates worldwide, and it was primarily because of issues surrounding a lack of public health infrastructure. You know, and infectious diseases were probably the predominant driving force that, you know, contributes to the high mortality rates. And, you know, over time, obviously, we've had many public health successes, and we've had vaccines, and we've eradicated smallpox, and life expectancy has increased, infant mortality has decreased, and some of the communicable diseases are now actually eliminated. But with that change, there comes the whole issue of pandemics. In this scenario, we have now a slow rise in degenerative or chronic diseases, while there's still improved life expectancy. So we have people who are aging, and with that comes along chronic conditions. So, you know, as we look at different populations or different countries, this is sort of the picture that you see. The black line shows that population numbers are increasing and birth rates and death rates are decreasing. But the question we want to ask is, are we really healthier, right? This is where we are today. You know, there is a rise in living standards. We have a decline in fertility. We have comprehensive health care. But we have chronic diseases, and among them, cancer is one of the issues, and that's really what our focus is about today. Just to give you a little bit of a perspective even further, you know, as the transition in health occurs, the blue line shows the rise in heart disease, which is actually the #1 chronic disease that cause of mortality today. And right behind that is cancer, the pink line, okay? So over the decades, you'll see another example of how the shift has occurred. In the 1900s, cancer was actually the #7 leading cause of death. And when we get to the 2000s, it's not working, cancer has become the #2 cause of death, okay? And even more recently, this is actually data, I think this is 2014, which again shows that all cancers combined is the #2 leading cause of death in the United States. And when you look a little bit deeper, you begin to see the other cancers popping up, specifically prostate cancer being #4, lung cancer, #5, breast cancer, colorectal cancer. So we have while there have been many improvements in public health, we have now a new problem that we have to address. And along that comes disparities. And not to say that this is a dismal situation, because we've made many advances in technology, in science, in research, to really address these issues, and many accomplishments have been made. We know that if we look at the United States and we look at the number of survivors, cancer survivors, it actually, the numbers are increasing. over the years. So there are more people actually living with having had a diagnosis of cancer. But yet, there is still a disparity. And I just wanted to kind of throw in here the definition, at least this is sort of the NIH definition of what a disparity really is. It's a difference in incidence, prevalence, mortality, or burden of disease, and other adverse health conditions that exist among specific population groups in the United States. So this is a very broad definition. You know, we're talking about racial disparities, but there are many, many types of disparities. There are gender disparities when it comes to cancer, along with racial and ethnic disparities, and there's also geographic disparities. Here are some examples. This is simply the cancer incidence in the United States. I think this data went back, this is 2012 data. And you can clearly see that the incidence rates for cancer among males is higher than it is for females, both in incidence but also in mortality. Here's another example. These are cancers of the mouth and throat, where it's a predominant male disease. Twice as many males are diagnosed with this disease than there are females. And while there is also, along with that, racial disparities in combination. So you tend to have higher, well, this is oral cavity. Actually, for other sites of the head and neck, the racial disparities becomes even more apparent, where African Americans actually have the highest incidence. So here's a real issue, and this is what we're here to talk about. The fact that particularly African Americans, when it comes to cancer, have the higher incidence of cancer diagnosed and a higher mortality rates compared to the non-white counterparts. You know, I got these data from the NCI, and it was interesting when we tried to generate these charts that the other ethnic groups were not even plotted on this particular chart because the rates are so low. Okay, so that's another question. Why is that? Well, let's look a little bit deeper because we were just talking about all cancers combined. So here are some specific differences. Actually, for lung cancer, when it comes to death rates, there's not much of a difference between Black Americans and white Americans when it comes to lung cancer. But for prostate cancer, there is. The blue bars refer to the rates for Black or African Americans, and the orange or yellow bars refer to the white counterparts. Similarly for breast cancer, and as well for colorectal cancer. So these disparities are actually real, and they're real across the board for most cancers. Geographically, you see the same pattern where higher rates are observed in some countries and lower rates are observed in other countries. And you know, you can pick a country and see where it falls, but the variation in incidence and mortality is real geographically. I added this bar chart to the right just to show you an example of the geographic variance of prostate cancer specifically as it relates to Black men in comparison to white men, where African American men actually have the highest incidence of prostate cancer, second to white men, and then one particular country in the Caribbean, which also has a high rate of prostate cancer, actually is lower in comparison. So what are some of these contributing factors to cancer health disparities or racial disparities? Well, when we look back and we do all of the research that we do, we've actually come to the realization that there really are very few, I would say few, one, two, and three, the first three bars are probably the three most prominent risk factors that are attributed to cancer development. The primary cause is tobacco, which actually contributes to more than 30% of all cancers. Second to that is obesity. And then after that, we have infectious agents. So just looking at the first two risk factors, these are modifiable. These are issues that we can change if we know how to do it right. These are definitely risk factors that we can address. So let's talk about smoking. Well, you know, tobacco and cancer is a very big problem, and it's a very complicated risk factor in that it composes numerous types of chemicals in tobacco smoke that actually contributes to damage to our bodies and damage to the cells that results in ultimately cancer development. And when we think about the cancers that are attributed to tobacco smoke or tobacco use, it's not just lung cancer. How many community members actually know that? People in the general public know that smoking is not just the primary cause of lung cancer. It's the cause of head and neck cancer, cancers in the mouth and the throat, esophageal cancer, and many other cancers that you see here on the list are primarily also attributed to tobacco use. Secondhand smoke exposure is also another major issue because it has been shown in research to be associated with a number of cancers in non-smokers. Again, the head and neck cancers are at the top of the list. Then you have brain and bladder and rectal cancers and stomach and breast. So why do we have disparities? You know, if we're thinking about tobacco-related cancers, then one question could be, well, is it possible that there are differences in just the consumption or the utilization or the use of smoking? And yes, that is indeed real because we actually can show over the years from this chart that if you look at different countries, the consumption of tobacco actually has changed over time. And that could actually contribute to some of the disparities that we see. But for the United States, let's look at that a little bit closer. These are data from the NIH, which actually shows the percentage of recent smoking cessation successes among individuals who are 18 and older from the time frame between 1998 to 2010. And you see a very clear difference in pattern when you look at different racial or ethnic groups. You see actually a slight incline in cessation among Black individuals, also for Hispanics, but not much of a change for Caucasians. And so we have to really begin to think about behaviors and differences in behaviors according to race to show that these are some of the real contributors to the disparities that we see. Here are some examples of the geographic disparities as it relates to smoking. Smoking prevalence. These are data from 1980 to 2012 from a number of different countries. Many of them are actually in the Caribbean, and I've thrown in the United States, US, African Americans here, and South Africa just as comparisons. And, you know, for the most part, you can see that there's a very wide variation, broad variations in smoking prevalence. The various colors that you see here are different time points. So, for example, these are data for Trinidad, where in 1980, the prevalence was very, very high, and it's dropped since then for 1996, and then even lower in 2006, and sort of has been the same since then. But for some countries, like, for example, Jamaica, it really hasn't changed much. So not just looking at the prevalence of smoking in a population, but how that prevalence is changing over time gives you some perspective of all of the different things that can actually contribute to disparities in the outcome, which is the cancer. So how about obesity? This is the second highest contributing factor to cancer diagnosis. Well, there are a number of cancers, again, that are contributed to obesity, not just breast and colorectal cancer, but endometrial and esophageal and many others. How about the United States? What's going on? Well, in 1985, this is what the United States actually looked like when it comes to obesity. And this is the color shades here refer to an individual or individuals where BMI is greater than 30. And as we roll forward through time, this gives you a sense of what's been happening to the United States. 2000, 2001. Okay, this is where we were in 2010. not only do we have a pattern of increasing obesity, a prevalence of obesity in the United States, but there's also quite a bit of a variation in obesity across the various states, okay? Again, this just gives you a perspective of what we're talking about when we talk about factors that contribute to disparities. Well, what is it really that contributes to disparities? Well, here's an example, and you know, all of these examples, many of them are coming out of research that's being done, and so here's an example of an analysis that actually looks at the incidence of colorectal cancer in different populations. And when we look at the rates for populations or of individuals that actually are living in Japan, so these are Japanese individuals, that is sort of what the incidence of colorectal cancer is. And when we actually look at Japanese families that have migrated to the United States, this is what we get in terms of incidence, just as comparable to what's typically seen in the US population of non-Japanese individuals. So this data actually suggests very clearly that it's not just genetics that contributes to disparities, but behavior and diet in itself could be one major contribution to the differences that you see in different populations. Racial disparities and diet as it relates to the different racial groups in the US. So these are data that actually show how much of a consumption we have, you know, in terms of fresh fruits and vegetables in the United States, broken down by race. And what do you see? In the light blue line, the light blue line represents the data for non-Hispanic blacks, and the purple line refers to the data for Hispanics. So again, you see a variation in behavior, which obviously ultimately could lead to some of the explanations or understandings as to why we have these differences, racial disparities in cancer development because of behavior. Screening behaviors also contribute to racial disparities. Colorectal cancer screening. This is a picture in the United States currently. The Healthy People 2020 target is to increase colorectal cancer screening to 70.5%. What we see here is that Hispanics actually have the lowest screening rates over time. No one has actually reached the target except for maybe non-Hispanic whites who are approaching that target. And non-Hispanic blacks are also approaching but still below the target. So another example of variations according to race in screening behavior. Obviously, we know that screening for colorectal cancer is an important practice that we need to ensure early detection and ultimately the lower likelihood of a diagnosis of colorectal cancer. Here are some examples I'm going to show you about treatment differences and how that could also contribute to racial disparities. So this was a project that was done actually here while I was at Downstate on faculty. And we this is an epidemiological analysis of survival for prostate cancer among Black men diagnosed here in Brooklyn. And we compared the data for the Brooklyn men with data from 2 Caribbean countries, in Trinidad and Tobago and Guyana. And for the most part, what we found, the FAR Kaplan-Meier plots, these are the survival plots, actually show that here is Trinidad and Tobago. I'm having a hard time with this. Okay, this is the survival plot for the men diagnosed in Trinidad and Guyana. Very low survival compared to the Brooklyn men. Okay, so that was one point. There is a clear difference in survival. The death rates in the Caribbean actually are higher than the US or the Brooklyn men. However, when we just looked at the Brooklyn men, and we stratified based on whether or not they were US born, African American, we refer to them as US born, compared them to immigrant Caribbean-born men, there was actually no difference in survival. So here is a perfect example where we had Caribbean-born men in the United States that have a very similar survival rate to US-born men. However, we have the same similar Caribbean-born men in their native country having a poor survival rate. There are many, many different explanations that could be made, but clearly it does not suggest that this is a biological effect. Okay? However, we had some other observations. These are the data according to stage of diagnosis. So for the most part, most of the men, whether they were born in the US or immigrated to the US or were in the Caribbean specifically, the majority of these men were diagnosed with early or intermediate stage disease, 1 and 2. But you'll see the purple bar shows for stage 4 that the men in Trinidad Tobago actually had a higher proportion of advanced stage. But what we noticed that was very interesting was that if we just looked at the Caribbean-born men, those in Brooklyn, I'm sorry, this is a little bit off, the 82% survival rate refers to the men who were Caribbean-born in Brooklyn, and the 41% survival rate refers to the Caribbean-born men in Trinidad and Tobago. So these are men that had the same stage diagnosis, stage 1 or 3, 1 to 3, but yet different survival rates, okay? So we looked at this a little bit further to try to understand why is it then that we have a difference in survival rate when they were presented with at the same stage or similar stage. A very clear difference in treatment. What we saw was that the men who were diagnosed in Trinidad were actually primarily being treated with androgen deprivation therapy, and these are early intermediate stage diagnoses. Most were treated with androgen deprivation therapy or no treatment at all, versus the Brooklyn men being treated with surgery and radiation. So there is a clear difference in terms of the pattern of treatment. And that was our first indication that treatment strategy actually does make a difference, and it could actually contribute to disparities in mortality. And here's an example of 2 populations, similar biological backgrounds, but treated differently with poor outcomes for one group over another. Okay, so there are so many other issues surrounding racial disparities in cancer, and I'll touch on a few more as examples. One example that we really often, most people actually don't really think about is this difference in methodological research, the way we collect our data when we're doing research, how we analyze our data actually does make a difference. Because if we are using different tools, instruments, surveys, however, whatever it is that we use to collect the data, if you have groups that are collecting this in a non-consistent way, there really is no real way for you to comprehensively review and come to a conclusion that makes sense because of the differences in the way that populations are actually recruited, the way that the data is being collected. And this was something that we've recognized, at least within our research group, very early on, and we actually have an alliance now with 3 distinct consortia to actually standardize the way that we collect our data. And so we're developing standardized tools for data collection for Black men to address prostate cancer. And this will be a global effort. And these tools hopefully will be released in November. So that's one of the achievements that we're very happy about, which will help to allow us to be able to collect data that will be more consistent across groups, and so that we can be more powerful in the way that we actually come to our conclusions. Okay, biological differences. This is a real issue, and I just want to kind of touch on this because I don't think I have enough time to really talk about some of the biological differences in great detail, but I think we really need to be very mindful and aware that this also is a contributing factor to racial disparities in cancer. I'm not sure how many of you actually recognize this type of a plot, but this is a typical plot that actually shows genetic ancestry according to different populations. And so these are actually bar charts, but just really, really close together. And it represents a number of different populations on the far part of the screen. The blue bars refer to genetic markers or populations that have a high proportion of certain genetic markers, and that's what's represented with the blue bar. The red bars are the genetic markers that are typically found in African populations. And the yellow bars, I believe that's the Amerindian population. But then you begin to start looking at other populations where you see this sort of a rainbow effect, where other populations are actually quite mixed, okay? So these are genetic markers. We refer to them as ancestry informative markers. We all carry ancestry informative markers, but some individuals may have a certain proportion of African ancestry that might be different from another individual. And similarly for Caucasians, there are also markers that are typically found, or alleles that are typically used to identify European populations. So here is an example of how ancestry could actually impact risk. This is an epidemiological analysis. It actually is an analysis of one particular polymorphism as it relates to prostate cancer development. So as an epidemiologist, typically we do case control studies, and this is an example of the effect of genotype on prostate cancer. And I just want to bring your attention to the red square and sort of walk you through it. So the first set of results here are odds ratios that show the association of these particular alleles with the development of prostate cancer. So if an individual has 2 Gs in that specific loci, then their risk of prostate cancer is actually increased. The odds ratio is 1.74, so it's greater than 1, and it's statistically significant. So this shows that individuals who have a GG in this particular locus have an increased risk of prostate cancer. And in addition to that, if you were to look at the CC, which is the alternative allele, you see a reduction of risk. The odds ratio is less than 1, okay? That makes perfect sense. Well, what if we stratified this population based on race? So here are the Caucasians. This is the data for the Caucasians. Okay, right here. Again, GG shows an increased risk of prostate cancer. CC shows a protective effect. Okay, what about the African Americans? Well, for GG, there's actually no association with prostate cancer. And for CC, there's an increased risk, okay? So this is just one example of many that really suggests that genetics really do matter if you're looking in the right places, right? And so this is so important for us to be mindful of the fact that when we do especially genetic studies and we look at the association of genetic markers with respect to disease, we have to be very careful about the population that we're looking at and really ask the question, are there differences within different racial populations? And how do these differences impact health? Okay. Here's another example of why genetics matters. And we're in this era of precision medicine, where we're really very keen on trying to ensure that we're making decisions that are going to be tailored to improving the health of an individual. And so let's just say, for example, this cartoon shows you just how different populations might vary. And so the first 3 individuals, just pretend that this is their DNA sequence. And because these 3 individuals are from a particular race, you might find at a particular locus the prominence of a certain marker. So you see this colored, the darker color is represented across the board for this particular group of individuals. And you have a different population where, because this is a different racial group at this particular locus, there's a difference in terms of allele. Well, and there have been research studies that have shown this, that, well, when you look at the different populations and you treat this particular, disease with a drug, you find that these individuals are less responsive to the others. Well, it boils down to ancestry. It gives you this just provides some sort of an example to show that even when we think about treatment and the way that we metabolize drugs or the way that we handle certain types of therapies, there might actually be some inherent slight differences that could impact outcome. And so these are other examples that show that even biology or genetics can actually contribute to racial disparities. So the bottom line here is that, yes, education and awareness is key. We know that we have to educate the population. We know that we have to raise awareness. We know that we have to promote screening so that all of the community benefits from the importance of screening. But research also makes a difference. And this is another way that we can tackle racial disparities, by asking the type of questions that will help us to understand some of the population differences and how we can go about addressing these differences to really improve or prevent the disparities that do exist. One way, I'm inundating you with a lot of examples because I really want the take-home message to be, to allow you to be able to really think about different ways that, that racial disparities exist, and the fact that there are a lot of different factors that contribute to these differences. So here's another project with some preliminary results that we've just generated from a cohort that we have, that we're developing in Philadelphia. And we asked a simple question. If we were to, we all know from the speakers this morning, from Dr. Roberts and many of the other speakers, the importance of screening, especially for prostate cancer, and the importance of screening in Black men for prostate cancer. And so one of the questions that we started to ask ourselves was, well, how do we really begin to develop interventions that are going to be appropriate and effective for Black men to promote screening? Screening is a complicated issue, and we also know about the screening recommendations, particularly the fact that now men really have to make an informed decision about this, about their risks and all of the uncertainties, and make that decision with regard to PSA screening. And so having a conversation with your doctor is a big deal. Healthcare access is a big deal. So we looked at this a little bit, particularly interested in looking at the Black men in Philadelphia, but not just looking at Black men as one group, but realizing that there may actually be some cultural differences that might impact decision making. And we pulled our data and showed that irrespective of which group of men, so we actually had a representation of US-born Black men in this particular study, Caribbean-born men, immigrants, and African-born men who migrated to the United States. Well, all three of these groups actually had a pretty decent relationship with their provider, and all three of these groups had a pretty decent screening rate. Okay, so that was good. But then when we asked them, well, what was it that helped you decide to be screened? And what was interesting was that even the way that they made their decision was very different. When we looked at the US-born men, we actually found that they were the ones that it was their responsibility. They felt like they had to be the ones to make the decision to be screened. But when we compared to the Caribbean-born men, they preferred that the healthcare provider make that decision for them, okay? And the African men actually didn't care one way or another, whether they made the decision or the healthcare provider made the decision or both of them made it together. There was sort of an equal representation across that group. This suggested to us that even within the Black population, there are some very clear differences, and it possibly could be related to culture. There are differences in even the way men make decisions about screening. So if we're going to think about an effective and successful intervention to promote screening, then these subtle differences are very important. It's important for us to know then, well, if the US-born men think a certain way, then this is how we have to tailor our intervention to address the issue. And similarly for Caribbean-born immigrants as well as African immigrants. So here again, it's so important to realize that research really does make a difference because it helps to provide us with a lot of information that's going to help us to be more precise in the way that we, we address this issue regarding racial disparities in cancer. So, and it's a very complicated thing, as you can see. There are so many different factors that contribute to racial disparities. There are social cultural differences. There are differences in the physical environment, biological differences, which we touched on, differences which relate to access to care. And all of these differences actually do interact and interplay with each other. So it's not really an easy answer, but it's something that we have to always be mindful of, that we can't take a reductionist approach. We have to think a little bit broadly sometimes to really begin to try to answer some of the unanswered questions that we still have with regard to racial disparities. One of the ways that we have been trying to address this is through collaboration, because we recognize that no one researcher or no one health professional or no one community stakeholder can be the answer. We all have to work together as a team. And we all have to work together with different expertise and different perspectives to be able to tackle this complex condition that is racial disparities. And so we have a network that we have established. We've been together for about 9 years. And we are looking at some of these differences within Black populations, within the United States, as well as the Caribbean and Africa. And it's the African Caribbean Cancer Consortium. And we have, we're supported by the NIH, which is great. But one of the key things here is that we are transdisciplinary. So we have representatives from various different disciplines that are with the goal of trying to come together to look at disparities in a unique way through advocacy, epidemiology, medicine, community health, and so on. And we are also in our network across different geographic regions, and we're able to come together as a team to really look at populations in different contexts and make comparisons. So this is, I feel, a very powerful way through teamwork that we can begin to really start to do the type of research that's going to be able to address some of the disparities in our populations. So I think I'm going to stop here because I'm probably running out of time, but just know that our consortium is organized where we are focusing on many different cancers. There are women's cancers, colorectal cancers, urological cancers that are being studied within our groups, and we are always looking for opportunities for research collaborations. And so we have a structure in place where we can work with others in many different ways to begin to work together as a team to address cancer, especially in populations of African ancestry. And thank you. Leave it there.
Are there any questions? Okay, yes.
During your presentation, you said through your consortium, you are trying to develop new guidelines on data collection and analysis on cancer patients. But there is the North American Association of Cancer Registries, which has specific guidelines on how data have to be collected on cancer patients, and the accreditation that they give is highly regarded by different centers that treat cancer patients. So I wanted to know what those the guidelines that you are going to develop will add to what the North American Association Cancer Registry already set as information to be gathered on patients with cancer. Thank you.
So for clarification, what I talked about was the development of instruments that we were using, data collection instruments. These are primarily epidemiological instruments. And so what we plan to collect we actually have 3 distinct areas that we're focusing on. There's a clinical aspect, which obviously will go in line with the guidelines that have been presented already. But then there's also a behavioral component where we are actually developing a unified tool to address the behavioral piece, psychosocial stress and all of those issues surrounding behavior. And then there's an epidemiological component, which really ties in all of the risk factors, the various types of environmental exposures, race, ethnicity, family history, all of those different factors it's very comprehensive. So it's more than just the standard guidelines that are currently in existence, but it actually is a more comprehensive tool that really looks at the biological environment that the individual is in, the physical environment, the mental environment to address behavior, and then also the clinical data as well.
I have a second question. When you were presenting the table when you were talking about the odds ratios of the association between the different genes, the race and the risk of cancer, we all know that in epidemiology, association doesn't mean causation.
Absolutely right.
So I wanted to know if you went further to see if, not to prove, but to show that there was actually a biological association between those genes and the risk of cancer.
Right. So the table that was presented in the slides actually was a publication. It was not our work. I just use it as an example. But we do have some examples in our work currently where we have looked at ancestry informative markers and have seen a change. And we've now taken the next step to look at some of the biological implications. So we've looked at gene expression changes, and we can verify that in fact these polymorphisms are actually really doing something biologically. And then of course we're continuing to do that work to look even further to begin to understand the mechanisms behind it, to really be sure to really confirm or validate the observation that we've made.
I have a very quick question. In your Africa studies, it looked to me as though you had 3 East African countries involved. Ethiopia, it looked like Malawi, I don't even remember what one.
Kenya.
Probably Kenya.
Yes.
But you don't have any from the West
The
Africa.
West, right.
And I think that that's going to be critically important, just from the long history of the slave trade and everything else, to figure that one out.
Yes.
How are you going to go about organizing and getting people from West African countries involved
Right.
in that process?
So, yes, so so we do not currently have boots on the ground in West Africa, but we have strong collaborative ties with researchers that have boots on the ground in West Africa. So when I talked about the Tri-Consortium Alliance, which was one way where we were talking about the unified tool that we're developing, one of the consortium that we collaborate very closely with is the Transatlantic Prostate Cancer Consortium. And they are primarily focused on Nigeria and the West African countries. So through collaboration, we will be able to access those populations and do studies. So it will be feasible.
Thank you.